All right, we can't improve on that, so we'll just call it a day. How about that? Thank you, Dave. That was very nice of you. We are very proud and pleased to have Alex Hewitt on our team in Washington, D.C., and we are from Washington, D.C. I learned a long time ago when I grew up in Kentucky that an expert was somebody from out of town. Well, we're way out of town. Now, Carrie and I do believe we have some expertise we can share with you today, but we do not believe we are truly experts. In fact, what's going on in the Affordable Care Act and the implementation of it is the old saying about out of chaos comes opportunity. And that's part of the message we just heard from Joe, I think. Out of chaos comes real opportunity. There's a tremendous opportunity to direct the leadership of the healthcare institutions in this country who embrace and begin to implement various aspects of the new law. But there's going to be a lot of upheaval as well. We did a little survey before we came here. Many of you may have participated, where we asked you, one of the questions was, on a scale of 1 to 5, how comfortable do you feel in your knowledge level of the Affordable Care Act? 1 being, I don't know a darn thing about it. 5 being, I'm a world-class expert. Well, here are the answers from South Dakota. As you can see, they're heavily weighted between I know something about it to nothing, with a very few people saying they were pretty confident in what they knew. Now, there's one person who said that they were a world-class expert. I don't think they understood the grading scale. They thought 5 was no knowledge instead of all knowledge. So to pick up on what Theismann was saying, let's take ourselves back to the famous football coach, Vince Lombardi. I'm told that Vince Lombardi, when he coached the Green Bay Packers, every year, every season, on the first day of practice, he would call the team together, and he'd get them in a big circle, and he'd pick up a football, and he'd say, gentlemen, this is a football. He'd say, you gentlemen on the offense, your job is to take this football and put it in the end zone. You fellows on the defense, your job is to keep them from putting it in the end zone. Are there any questions? One player once said, Coach, you're going too fast. So we're not here to make experts out of anybody in the room, because this stuff changes all the time, every day. It's a 24/7 operation. Things get postponed, things get modified, people are all up in arms about it. And we're not here to talk about policy either. We're here to talk about what's real and in front of us. The United States Supreme Court has already ruled 6-3 that this law is going forward, so the wise folks are getting ahead of the curve, not waiting for it to disappear. So our message and our mission today here is to have a conversation. As Carrie and I thought about this, we do a program that's attached to our website called Let's Talk Accountable Care. And on that program, we bring in some people who are distinguished healthcare leaders, and we interview them, sometimes video, sometimes audio, but you can go and see the video or the podcast if you wish. But it's a conversation instead of a lecture. We're only going to use 3 or 4 slides here just as reference points. We're not going to use a big fancy PowerPoint. We're just going to talk. And the conversation is mostly going to be between Carrie and I discussing these issues. And we have a handout, a discussion guide that's in front of each and every one of you if you want to follow along. But we may not even follow it directly ourselves. But it gives you an idea of the issues and the topics that we'll try to touch on before we finish today. And we'll hopefully save a few minutes at the end for any questions you may have. And I will myself, from time to time, refer down to my notes. I figure if Brian Williams can use notes on the international news every night, I can use notes here in South Dakota. Carrie, why don't you get us off by talking about change? You know, one of my favorite soul singers was a man named Sam Cooke. And he had a famous song called A Change Is Gonna Come. Of course, he was singing about the civil rights movement. That change has come. We got a new change in healthcare that's equally as important. So Carrie, why don't you get us started with some of your observations?
Sure. I think the bottom line is that change is here. Everyone in this room knows that. Everyone in this room understands the problem, right? They know that costs have gotten totally out of control. Everyone knows that the U.S. spends the highest percentage of GDP on health care as any country in the world. Yet our quality of care and our outcomes don't really match up with that figure. So everyone in this room knows that something has got to change, and the time is now. So, this is something that's recognized, that has been recognized in the private sector for a long time now. for several years anyway. I mean, everyone talks about Obamacare as being, you know, sort of the beginning of change in healthcare reform, when the truth is some of the private payers and some of the folks in the industry sort of saw this coming a long time ago. Carson, do you remember when you and I, several months before, well, about a month.
When we saw Reed?
Yeah, about a month before the Affordable Care Act was deemed constitutional by the Supreme Court, Carson and I attended some kind of a conference. And Reed Tuckson, who is the chair, no, I guess he is the chief medical director for United Healthcare, was speaking. Carson, I think you know him from...
Yeah, Reed and I were on the board of the National Patient Safety Foundation together for a few years. And I got to tell you, and I told him afterwards, I had never seen him more animated about something than the presentation he made that day. He was all over the room. He was bouncing up and down. And he was excited because what he was really telling us is it doesn't matter what the Supreme Court does. The train's already left the station. We, the private payers, he's United Healthcare, are implementing the ACO concept regardless of what they do because it's right. I was very moved by Reed that day.
That's exactly right. The passion that he clearly felt about this issue was apparent to everyone. And in fact, it inspired Carson and I to write an article that was published in the Wall Street Journal, the Marketplace edition, you know, along those lines. Basically, the Supreme Court decision in Obamacare doesn't really make that much of a difference because the train's left the station. And kind of fortunately for us, it actually was published the day before the Supreme Court decision came down, so that was...
Actually, we timed it that way, you know. We control the Wall Street Journal. We told them what to do.
No, we control the Supreme Court.
Oh,
right?
that too. Yeah.
Right, exactly. Exactly. So, you know, the private sector has known for a long time that something had to change, and they've been working toward that. And they've been, you know, thinking about payment models that incentivize the quality of care over the quantity of the services provided. And they've been thinking, in fact, about ACOs, accountable care organizations, long before they became, you know, a term that was associated with the Medicare Shared Savings Program. I cannot thank you enough for inviting Joe Theismann, Dave, to kick this event off. You know,
She's got a crush on Theismann. Even her husband knows about it.
Yeah, he does, and he's going to love this picture that we just snapped of Joe and myself. That's going to be going up on... She's a lifelong
Redskins fan, born and raised in Northern Virginia. She's crazy about these people.
It will be going up on Facebook the moment that we leave this session. But, you know, I grew up in D.C. during the Joe Theismann, Joe Riggins, you know, heyday of the Washington Redskins, Joe Gibbs. And it was just, you know, it was just such the appropriate kickoff, I think, for this particular topic. You know,
I have to tell you, he was 2 times better than I thought he was going to be.
Really great. I thought he was excellent, and I think his approach is exactly the approach that Carson and I believe that we need to take to healthcare going forward. You know, change is a challenge, but it's also an opportunity, and the ball is really in our court to take it, you know, to take it and to do with it what we can and to make it work for us. You know, the challenge is, I mean, organizations have all kinds of inertia. They don't like change, right? They're very slow moving. Everyone thinks we've got to do it this way because this is the way it's always been done, and how else can we do it? You know, that it's not going to work another way. You have to really kind of chip away at that. Actually, it's better to actually just sort of blow it up and say, you know what, we can do things differently. We need to get out of the mindset of, you know, we can't change, this is the way we have to do it, you know, it's not going to work. We've got to sort of blow that mindset out of the water and say, what can we do to make healthcare reform work for us? I think what we're seeing with a lot of the models that are popping up all around the country is that there is no sort of one-size-fits-all solution. You know, we are seeing many healthcare entities who are engaging in some models that are very successful. And those models may look very different, but they're succeeding. And we're seeing some that are engaging in models that, you know, that aren't succeeding. There's no one-size-fits-all. I think the thing that we have to do is to craft an approach that really works for the population that you serve and for you. You know, and this doesn't apply just to doctors, and it doesn't, you know, doctors groups, and it doesn't apply just to hospitals. You know, post-acute has a real role to play in this as well. I know we have a lot of post-acute care providers.
Can we stop on that for just a moment? Because why don't you share with them some of the webinar that we did on post-acute care and the creation of post-acute care networks?
Yeah, both Carson and I have spent a good deal of time in our careers working with long-term care providers and in the post-acute care space. And we both feel pretty passionately that, you know, long-term care and post-acute care has been sort of left out of the healthcare reform conversation. You know, some of you all may feel that way as well. And we think it's kind of, it's interesting, and it's a real oversight, because post-acute has a significant role to play in how healthcare reform takes shape in our country. You know, we did a webinar that talked about post-acute care networks and how those networks can, you know, go from adult daycare to home care to assisted living to SNF to, you know, rehab services to hospice, really, to integrate and to play a significant role in, you know, providing lower cost care, or very quality care in lower cost settings, and into reducing the readmissions that hospitals are now being penalized for. So, you know, we're encouraging post-acute care providers in particular to think about how can they best position themselves to other you know, providers, other parts of the system, and say, you know, look, we have a role to play, and we actually, you know, we want to work with you, we want to integrate with you, but we actually also want to be sharing in some of the savings that you all are generating because of us. And by the same token, hospital systems should be looking to post-acute and saying, we are going to work with post-acute providers who have shown us that they are integrated and that they really have a track record of success in you know, providing high-quality care in lower-cost settings.
Once upon a time in my career, I was the CEO of a company that had about 2,500 employees and $100 million in revenue in long-term care and home care. If I were still running that company today, what I'd be working on is in the communities, and we were in a lot of them in several different states, developing networks so I could turn to the major hospitals and the leading physician practices who are forming ACOs and say, we'll take care of everybody outside the physician practice in the hospital setting. One-stop shopping. Come to us. We've got nursing homes here in the community that are quality. They've got the data, they've got the information technology in place. They've got great testimonials and reviews from accrediting agencies. The same with home care, the same with hospice, the same with key therapists. And I would turn to the hospital leadership and say, you need to be contracting with us as a unit, because for XYZ dollars, we'll take care of anybody you send to us, and we'll keep them out of your hospital. Again, you'll make more money because of it. For the life of me, I don't know why people aren't seizing that initiative. It seems obvious. It's laying out there. Just all you got to do is grab it.
So it's an opportunity, right? So challenges and opportunities. It's true across the board. It's true here in South Dakota. We sent out a survey that several of you were kind enough to respond to in advance of our presentation, because we wanted
including the expert.
Exactly, including the expert. Because we wanted to hear from you all, you know, what you view as your challenges and opportunities, and I want to share some of those with you. So on the one hand, admissions are down. What does that mean? Y'all are doing too good of a job, right? Your wellness programs and your preventive care programs are working, and you all are experiencing fewer admissions, but that means you're getting less revenue, right? So that's a challenge and an opportunity. You all need to reduce your bad debt. You've got some bad debt out there that's holding you down, and you want to figure out how to reduce that bad debt. Federal scrutiny. The feds are really getting on your nerves. They are breathing down your neck. They're causing, you know, they're breathing down your neck with all of these regulations and, you know, new and more regulations that they're constantly imposing. And, you know, they're making noise about taking a look at the Medicare funding for critical access hospitals, you know, all those kinds of things. And they're creating a lot of uncertainty, right? You're hearing all this stuff in the newspapers and in the trade publications, and you know, it's kind of a mystery. Well, where, you know, what's going to happen with the funding for critical access hospitals, and what does that mean for us? What are we going to do? So that's an area of concern for you all. You know, South Dakota, obviously a very rural area. You know, you have a great large state, and more, I think, you know, a much, you know, the majority of your state is obviously a rural area, and so that's very different than many other areas in the country, and so that poses some unique challenges and opportunities for you all. You know, you're interested in thinking about technology and telemedicine and how you might be able to use some of those things to bridge the gap and reach across those rural areas. Competition and consolidation, that's another thing you all are thinking about. You know,
now, remember, when she says that's what you're thinking about, this is your answers to our survey question. This is what we learned that you told us you were thinking about.
So you know, we want to take a closer look at some of those things. So the question, Carson, I have for you now, let's talk about ACOs. I mean, okay. ACOs seem to be sort of the holy grail of healthcare reform, right? That's kind of how they're being touted, accountable care organizations. Do they hold the key to all of these challenges?
I wouldn't call them the holy grail, but I think they are a touchstone. And I think they can be an example of success. But remember what Theismann was saying today, and I agree with him 110%. Nobody's going to be successful without passion. Just to throw up an organization, call it an ACO, and not change attitudes and the way we care for people probably isn't going to accomplish very much. Remember that the real heart and soul of the Affordable Care Act is something called patient-centered care. How many of us have had the experience of been admitted to a hospital or seeing a physician and feeling like they talked over your head or around you or used terms and so forth you didn't fully understand? They weren't really focused on you. They were focused on what they needed to do. Busy days, lots of people to see, move along, hit it, you know, hit the ground running and keep going until nighttime. They got a lot of stuff going in their lives. And historically, there's a lot of surveys that show that people called patients don't feel that they're really focused on. And so this changing to a patient-centered care model, the ACO and its kind of cousin, patient-centered medical homes, those are entities that are cropping up because, if run properly, they will enhance the delivery of patient-centered care. I'm very passionate about patient safety. Served 10 years on the National Patient Safety Foundation board and studied a lot and learned a lot. And we can do a lot more in safety. But I think if we focus more on the patient experience and the family advocate and so forth, we'll enhance outcomes and improve quality. Remember this about quality. You can never have quality in the healthcare system if it's not fully safe. It can be fully safe and still not be quality. But it can never be quality if parts of it are inherently unsafe. So the triple aim of ACOs is to reduce costs, that's important, but the other two are maybe more important. Improve the health for a general population of a community, and improve the health care for individuals within that community. The NCQA, whom I'm sure many of you are familiar with, they're a national accrediting body, will accredit ACOs, and some of the ACOs have sought accreditation. And I wanted to share with you, I think this is in the discussion guide, isn't it? Mm-hmm. You may be able to look down and read it along with me. They have a very simple, straightforward definition for what an ACO is. It's an alliance of physicians, hospitals, and other providers that coordinates care for a particular group of patients to improve quality and reduce costs. Pretty simple statement. Hard to do, but a pretty simple statement. For example, Carrie and I, we may not be experts, but we've read a lot about this. I printed out the Medicare Shared Saving Program Final Rule, 463 pages. Read every word. The actual Affordable Care Act prints out at over 2,000 pages. Read most of it. Couldn't read every word, I went to sleep.
Part of the reason why we're not experts, I think, is because no one is really an expert right
That's
now,
right.
right? This is all a moving target and things are evolving.
It changes all the time. But let's look at how many ACOs we have. Alex, can you help me with that? Here's a map that somebody put together of Medicare ACOs. Now, what we're going to learn this afternoon is there are multiple types of ACOs, and they're not all for the benefit of Medicare. But you can look on the map there very quickly and find South Dakota. Not much action in South Dakota on Medicare ACOs. There's only 2 or 3 states with can't be less action than you guys, tied with you, Alabama being one, and North Dakota's not got much going either. But look over there in your neighboring state of Montana and Wyoming, or down to the south, or to the east. You're surrounded by heavy activity of ACO development. Now this is just Medicare ACOs, and let me look at my notes here. There are 253 right now Medicare ACOs. These are ones who qualified under the Medicare Shared Savings Program and contracted with CMS. However, there's a total of 488 ACOs in the whole country. Now this is the map that shows all ACOs. It includes the Medicare ACOs and everyone else. Once again, not much happening in South Dakota. Not much happening down in the deep south. But there's action in all the rest of the country, heavy action. Now, maybe it's not right to have ACOs in South Dakota, but you'll have to convince me why it can't work, why it's working other places and it couldn't work here. Maybe it just hasn't been tried yet. Maybe there's too much confusion.
Well, let's talk about that for a moment, actually, because I have a little bit of a breakdown on the numbers of ACOs in rural America. Now, you'll find that 65% of the ACOs that are currently in existence here that are shown up on this map are exclusively metropolitan area ACOs. And that's a much easier case to make for lots of reasons. But if you look at 32%, you'll see that 32% of these ACOs are a mix of metropolitan clients that they serve, and they also serve rural areas. So metropolitan and rural mix. 4% of them are exclusively rural ACOs. So that's nine of the ACOs are absolutely exclusively rural. And if you look at rural areas overall, you'll see that there are Medicare beneficiaries in 343 rural counties in 38 states that are assigned to 88 Medicare ACOs. And then overall, approximately 30 million Americans are currently being served by some form of an ACO, whether that's a Medicare Shared Savings Program ACO or some kind of hybrid of an MSSP and a private payer ACO. Carson, do you want to tell us a little bit about the other different types of ACOs that are out there?
Yeah, on your outline, we use the term flavors of ACOs like it's Ben and Jerry's or something. There's basically 7 different flavors. Some of them are like a renal ACO. I don't want to spend any time talking about it because it's very unique, and if you're not in the renal dialysis business, it wouldn't even apply to you. But there are 3 that I would like to touch on. What's called MSSP, which stands for Medicare Shared Savings Program. This is the one you've probably heard the most about. This is one where you have to take risk, but you can get rewards. And the rewards are tied to improving quality and reducing costs. There's what is called one-sided risk or two-sided risk. A lot of people are starting out with one-sided risk. That means there's no downside, there's only upside. You enter into a 3-year contract with CMS, and the first 2 years you can elect to have no downside risk. There are no penalties if you don't improve quality or reduce cost. However, by the 3rd year, they want you to take both sides of the equation. Some people are going ahead and saying, we know we can do this. We have the infrastructure in place, we've got the information technology, we've got the training, we've got the leadership, we can do it from the get-go. So they're taking both-sided risks. You may say, well, wow, that seems kind of stupid. They get more on the upside if they take both-sided risks than they would get if they only take the upside risk. So there's flavors of that within MSSPs. Now, in addition to MSSPs, one of the things about a Medicare Shared Savings Program, ACO, that is a challenge for a lot of rural providers. You have to have at least 5,000 Medicare beneficiaries in your ACO. They'll be assigned to you based upon their prior experience with their personal physicians and who's involved in the ACO. But in some places, if you look at the very narrow market that you're in, you might be tough to find 5,000 Medicare beneficiaries, right? So you may have to expand your geographic reach and your vision of what your market could be. And we'll show you some examples of that in a moment.
And to develop some partnerships with other types of providers that may get you to the 5,000. You know, the 5,000 is, it is a challenge, but I don't think it shouldn't be an insurmountable challenge.
And then a lot of people in other states, for example, in Billings, Montana, they've dealt with this beautifully and created a wide-ranging ACO with thousands and thousands of beneficiaries. The next one is called the advanced payment model. And this has been popular in rural America because it provides you with money up front, i.e. advance payment, to get up and running. The government recognized that particularly in rural America, there's a lack of electronic medical records, other types of information technology and data gathering. So they said, okay, fine, we're going to help you out. We'll give you an 18-month interest-free loan of X amount of dollars for you to hire staff and to implement new information technology. So the money's out there. Now they're going to want to be paid back over some period of time, but it's interest-free money. How often do you get interest-free money from anybody? So I would encourage you, if you're in a very rural area, to sit down, put a team of advisors together and begin to say, how can we get in this game? And you may come to the conclusion it's not the right game for you, and I will respect that. But what I can't respect is not even considering it and investigating it. The third is the leader of the pack. That's the private payer ACO. They don't get as much notoriety in the press because they're doing this on their own. And we'll talk about some of the challenges and issues of partnering with a private payer and creating an ACO like that in a few minutes. But these are the three main flavors: MSSP, advanced payment, and private payer. Carrie, you want to pick up on that?
Yeah, to tag on for a moment about the private payers, you know, Carson said they're doing this on their own. There's some significant benefits to that, right? You know, they don't have to have the 5,000 beneficiaries participating. You know, they're not operating in the constraints of the 400 and some page, whatever it is, right, MSSP rule. So they're able to act a little more creatively in partnership with some of the providers to set up some really interesting and really innovative and unique models. You know, they can set their own benchmarks. They're not, you know, they're not looking to CMS to set their benchmarks for them. And I even saw a study recently of private ACOs that have been in existence since 2009. And those ACOs have showed significant cost savings without sacrificing the care. Now, one of the downsides is that some of these commercial payers, you know, they may not really favor these, you know, all upside arrangements, right? With CMS, with the MSSP model, you can take the one-sided model, right, where you're not paying a penalty basically if you don't meet your benchmark. Commercial payers may not be quite as amenable to that. They want generally their providers to share a little bit of the risk with them. But again, you've got a lot of flexibility to work out an arrangement and to hammer something out that works for everyone.
You know, one thing I'd like to add, Carrie, about this, and I think it's very important. I think personally that one of the 2 or 3 most important provisions of the Affordable Care Act is the requirement that payers, health insurance companies, spend at least 80% of premium dollar on providing care. Now you may think, well, that sounds okay. Aren't they doing that? No, they're not. Read a book by Wendell Potter called Deadly Spin. He'll give you some insight. This man was the former vice president of government relations and PR for both Humana and United Healthcare. And he'll give you a lot of insight about how they were spending like 65 cents out of the dollar and the rest of the money is going to shareholders. Once you bounce from 65% of a very big dollar to 80%, you got to figure out a way to spend that on care. Maybe a private payer ACO would be a good idea. Because if they don't spend 80%, they pay a penalty to the government equal to what they don't spend. So, a lot of incentives.
So let's take a moment to look at some case studies that we have selected from around the country. You know, organizations that have put together some interesting accountable care models. The case studies that we're going to share with you, we selected very purposely, you know, because we feel that these particular organizations face some of the same challenges that you all might face here in South Dakota, the challenges and the opportunities. And, you know, these case studies really highlight the no one-size-fits-all approach. The first one I want to talk about is called Eastern Maine Healthcare System. It's based up in Brewer, Maine, and they are a collaboration of 6 hospitals, including some critical access facilities. They rely primarily on public payers. They are about 2/3 Medicare or Medicaid, 10 to 15% uninsured, and 20%, about 20%, commercially insured. So they've got, they've got some challenges there. Now, one reason that we wanted to focus on Eastern Maine is because they are doing something there that you all, I think, are doing here, and that is they're almost doing their care too well, right? They experienced reduced admissions because they had to do this. They had to get very efficient in providing high quality care. And under the fee-for-service payment, they were being penalized for that, right? They were doing a lot of preventive things. They were doing a lot of wellness programs. They got very good at providing efficient and quality care, and their admissions were going down, and so was their revenue. So their problem was so bad in Maine that they said, we're going to jump in and we're going to be one of the pioneer ACOs. The Pioneer ACO program was put forward by CMS basically to encourage experimentation in models around the country to see sort of what works and what doesn't. And so they jumped right in. Eastern Maine had been having to constantly sort of raise their rates in the commercial market to compensate for the shortfall in other areas, right? But they knew that that was not sustainable. They were in this quandary, right? The financial benefit of doing the right thing by providing high quality care at a lower cost was really accruing solely to the payers. They weren't seeing any benefit from it. And this wasn't economically feasible for the providers. So they felt very strongly that they needed a different reimbursement model, and they jumped into the Pioneer ACO program. They're shifting their focus beyond inpatient needs. They're really looking to outpatient surgeries as a growth area as the baby boomers age. And they're doing a lot of work to grow their practice there. And they're seeing the results of sort of this new mindset in sharing savings and actually gaining in some of the savings. And they make a real effort to convey this, we are the pioneers. We are forging a path to a different and better way of doing things. They convey that to all of their clinicians and to all of their caregivers, and they really have, they've gotten everyone on board. And it's starting to pay off. But, even given their commitment, from the very top, there's still some fear there, right? We talked a little bit about the role that fear plays in our decisions at lunch today. And their board chairman is a guy named Jim.
Oh, you have that quote?
Yeah, Jim Nicholson.
Listen to this. This is good.
And he was asked about what it feels like to be a leader in pioneering a new model of healthcare. And he said, scary as hell. He said, we're all behind it. Make no mistake. We are behind this, but it's new. And we don't really know how it's going to play out. And that's scary. But they also knew that the status quo was not an option. So, Eastern Maine is one entity that bears sort of closer examination for you all, and we can talk more in detail about it anytime afterwards and look a little more closely at what they're doing. But I wanted to give you that overview. Carson, you want to talk a little bit about Billings?
Yeah, let's talk about one a little closer to home. Last night, Dave, I think you told me that the number was, on an average square mile, you had a density population of 9 people in South Dakota. Did I get that right? Per square mile, okay. What do you think it is in Montana? About the same, I would say. Do we have the slide about the Billings Clinic? So here in Billings, Montana, there's a clinic called the Billings Clinic. They decided they were going to create an ACO. They didn't have 5,000 Medicare beneficiaries, so they just created a big ACO. See all this shaded area up here? Those are all different areas that are part of this ACO, but they are part and parcel of it in different ways. If you had this right in front of you where you could see it more closely, in red, you may see real small red spots in various parts on the map. If you looked at it closely, it says TR. stands for teleradiology. There's similar black spots that say TM, telemedicine. So throughout their market area, which is about 2/3 of Montana and northern part of Wyoming, they're using a lot of outreach of teleradiology, telemedicine, and other things. They weren't letting geography hold them back. But one thing that if I were sitting in the audience instead of up here today, because Carrie and I, tomorrow, we're going to get a plane and go back to Washington, D.C. You're going to be here to figure out what you're going to do with accountable care. I would be looking at this map differently. Wow, look how much action they have on our border, North Dakota and South Dakota. Why don't they just come across the border like they did in Wyoming and start taking our patients? Why won't they just come over and start giving us new competition with new systems that they know how to operate? I would see these people as a major competitive threat. I have no inside information about whether they even want to come to the Dakotas. But I can see that map and say it's certainly possible. And they are very similar in substance and style and culture and history to the people in this room. This is not Florida or Southern California or Arizona or something. These are your closest neighbors. Now, they have been incredibly successful in developing this because I think the reason they're incredibly successful, they'll try almost anything.
Didn't they have some initial financial woes when they embarked on this?
I'm sure you're probably right. I don't know the details of that.
I think they were some quite
Well, let me tell you what's happened to them since then. They have 3,600 employees, 240 physicians, 85 physician assistants, 50 medical specialty areas, 9 critical access hospitals, 392,000 patient visits reported to Medicare last year. They have a hybrid of MSSP. They have bundled payments. They have private payer shared savings arrangements. They receive enhanced reimbursement through the Frontier States Amendment. They have a history of excellent quality and efficiency. They have a hookup with the Mayo Clinic where you can get advice directly from the Mayo Clinic if you're a patient of theirs. They've won dozens of awards for quality and so forth. They don't report their numbers publicly, so I don't really know exactly how their finances are going. You may be exactly right. But based on what I think is happening over there, I believe they weathered that storm.
I think you're correct. A wonderful system, but activity does not translate into that.
I agree with that. I've been in that boat before. Yeah, we had a lot of activity last month. How come we didn't make any money? I was in a law firm one time where we had the monthly meeting of the partners, and we determined that month the profit center was the Coke machine. You know, as they say up in New York, stuff happens. So I would look to Billings for a variety of reasons if I were in this room and going to be staying in South Dakota for the foreseeable future. What are they doing right? Try to avoid anything they're doing wrong, but get ready because they may be coming after you.
Yeah, you know, one of the things I think is kind of interesting about this model is that they really are a hybrid of a lot of different things. You know, they've incorporated some of the MSSP program. They've incorporated bundled payments. You know, they've got various different private payer shared savings arrangements. They really are doing everything they can.
As I said, they'll try anything.
Yeah, and you know, from what I understand too, you know, they do have a very similar to you all, a good history of quality care and efficient services.
What about Carolina? Carrie and I are doing quite a bit of work in Carolina. This is not a client of ours, but it's somebody that we know about, and we thought we would share some of the story of coastal Carolina with you.
Yeah, let's talk about coastal Carolina quality care. So this is an interesting one. I mean, as Carson and I mentioned, we're doing some work in North Carolina. We're helping some health clinics, some rural health clinics to merge where it makes sense to merge. They're looking at better positioning themselves, you know, to take advantage of the healthcare reforms, and in some cases, you know, that means consolidating where it makes sense to consolidate. So we're helping with some of those things. We're helping them to think through, you know, how to best position themselves in their rural areas in this era of healthcare reform. Coastal Carolina is an ACO. It's an advanced payment model ACO. Carson talked about those a little bit earlier. You know, they got some money up front to help with their infrastructure. Here's kind of the interesting thing. CMS estimated that the cost of starting up their ACO would be between...
Now listen to this number, it's pretty staggering.
Between $2 and $12 million. Now, I don't, that's kind of a,
Carrie
kind of
and
a
I-
big range, but
Carrie and I heard that and we said, how?
right. How does that happen? So CMS says we think it's going to take between $2 and $12 million for you to get this ACO up and running. Guess how much it cost them in the end? $250,000. It is up and running. In their first year of participation, they are seeing a 20% reduction in ER and hospital visits, and they're meeting their benchmarks. So one of the reasons why Coastal Carolina has gotten a lot of attention, you know, in addition to sort of that amazing figure, you know, starting up at $250,000 and meeting their benchmarks the first year, is they also have been very vocal about what it takes to get physicians on board, right? This is a physician-driven ACO, and they talk very explicitly about, you know, getting the physicians involved in the process from the outset. They talked about having their physicians look with them. You know, it was physicians and administrators and executives working hand in hand to look at the different models around the country and say, you know, what do you think? Would this work for us? What components could we bring to Coastal Carolina? What would work, what wouldn't? So the physicians were really, you know, on board right from day one. They were part of the process, and this created a lot of buy-in for them, and that is a really important aspect for success. You know, if you're trying to put together an ACO and your physicians, sort of like the linchpins of the whole thing, could really not, you know, they could care less and they think this is just another something that they've got to think about and mess with and do, it's just not going to work. But if your physicians are on board and you're able to start the ACO in a way that brings them on board right away, you know, you've got a much greater chance of success. Now, they attended something that CMS put on earlier on, I think it was 2011, called the Accelerated Development Learning Sessions. That, you know, it was a series of sessions that were put on with the sole purpose of really helping ACOs to get up off the ground and running, because at that point we didn't have a lot of other models, you know, to look at. You know, I don't know whether CMS is going to do additional programs. They haven't done them since 2011, but, you know, they had their physicians take part in that program, and we think it would be a good idea to, you know, have additional programs, even, you know, if the private sector was putting them on, to, you know, to basically get physicians on board with administrators to say, let's look at this, let's figure out, you know, how we can make this work. The bottom line with Coastal Carolina is they succeeded. They were a success story in having their physicians, you know, buy in completely and totally, and it seems to be paying off in their bottom line. One last one that I want to touch on briefly, and I don't think we put this one on the discussion guide because it didn't occur to me to do it then, but it's the Bellin ThedaCare Healthcare Partners, the Pioneer ACO. In Wisconsin, and some of y'all might be familiar with it. I mean, they have got, you know, Bellin and ThedaCare had contiguous markets, right, with similar demographics and similar economic bases, and they had common competitors. And so what did they do? I mean, they formed a joint venture to make themselves sort of more powerful, to broaden their resource base. And they did this early enough that they were then able to become a pioneer ACO on pretty solid footing to take the two-sided risk and to be, you know, to feel like they had a really integrated approach to succeed. They have 23 Medicare, or that must be 2,300 Medicare, 23,000 Medicare beneficiaries across 2 health systems, 700 providers, and 8 hospitals. They are clinically integrated across the 2 health systems, which I thought was really interesting, and you know, they share a similar electronic medical record system, which helps make that a little easier. I just think that's an interesting one to point out, because there you're talking about, you know, 2 entirely different health systems, which, you know, in previous lives, you know, could have been competitors, and they really kind of joined forces. And I don't know, there's a Rodney Dangerfield quote that they talked about that said, you know, my wife and I sleep in different bedrooms, we do different activities, we vacation separately, we're doing everything we can to make this marriage work, right? And I think that's kind of the attitude that Bellin ThedaCare has
But Belladin's
taken.
getting more respect than Rodney did.
Exactly. So anyway, that entity has, they've demonstrated savings well below their targets over 3 years. I mean, significantly below even their targets. Their targets were significantly below the national, and then they ended up coming in significantly below the targets that they set. So that's an interesting example to look at. So we've looked at some of these models from around the country. And the question that really comes to mind is, where do we go from here? So, Carson, you've been the CEO of 3 different healthcare entities during the course of your esteemed career, in addition to
I feel my
being
pain.
a healthcare lawyer and arguing before the Supreme Court and all that good stuff. So if you were wearing your healthcare executive hat, what would you be thinking about with respect to the challenges and the opportunities that we've talked about?
Now, I have some notes because she told me she was going to ask me that. So I'm prepared to answer the question. First thing I'd be thinking about is leadership. Do I have a team of people who can really grab this bull by the horns and make it happen? Theismann is absolutely correct when he talked about you need a team of people who are working towards the same goal in order to be successful. It's not a one-man band. Henry Ford was famous for saying, I'd rather have the productivity of 100 men, 1% of their productivity, than 100% of the productivity of one man. So it takes a cohesive effort. The Coastal Carolina example is a great example of physician-provider buy-in. Without the buy-in, forget it. You might get by with only $250,000. You won't have anything to show for it. So spend your resources wisely and build your leadership team. Now, in building your leadership team, you're probably going to have to do some training. This is an interesting statistic I ran across about 10 years ago. There's a trade association for everything, as we know, and there's one for training executives, the American Society of Training something or another. And they did an analysis of Fortune 500 companies one year, about year around 2000. And they found that they plotted out by ferreting through all the financial reports how much money each of these companies spent on training per capita, per head of their employees. Didn't matter what industry they're in. How much money did they spend? Didn't matter what they spent the money on. Just answering the phone training might qualify. Then they ranked them on the basis of how much they spent and what their return on investment was. All across the board, the more money, the people in the top quartile outperformed by 2 to 1 stock price of their peer group in the bottom quartile. They outperformed in bottom line revenue, return on investment, stockholder return, every criteria you could think of that financial folks use to evaluate the good or bad of an investment. The people who spent double the amount in training got more than double the success out of it. Training is essential. You can't ask somebody to serve on the board of a new organization and say, come on, sit down, let's go hold hands together and do something interesting. They have to be trained. And one of the things they have to be trained on is how to speak up. I've been on too many boards. I've been on a lot of boards in my life, for-profit and not-for-profit. And I've been on some that what I call get along to go along or go along to get along, whatever it is. Good old boy boards. If Joe says something, I'm not going to challenge it because Joe's a nice guy. And Joe, we have another relationship outside the board or something. There's a fly who wants to join me up here. I'm not as quick as Theismann. I couldn't grab it.
He may not have actually gotten it.
I think he was joking. But anyhow, I'll give you a great example of a bad board filled with really sharp people. Have you ever heard of Bernard Madoff? You know the man who made off with all the money? Well, Bernie Madoff got most of the money that he collected from Jewish investors in philanthropies that support Jewish causes. The vast majority of his money came out of a religious group because they believed in his integrity and his honor, and those were his friends. That was his group of circle of friends. One of those organizations was a philanthropy that had offices in New York and in Tel Aviv. They had their entire nest egg. It's not a small nest egg, $240 million. Gave it all to Madoff to invest. What do you think happened to that money? But that's not the reason I'm telling you the story. The reason I'm going to tell you the story is because it was a bad board with smart people. One day at a board meeting, about 3 months before all the stuff hit the fan, and everybody found out Bernie Madoff was nothing but a crook, they had a board meeting. And they had about a 15-minute break in the board meeting, and there was a guy we'll call Joe. He's a very prominent real estate developer in New York City worth billions of dollars. And he's on the board too. And he says, Bernie, we got like a 15-minute break here. Would you take a moment and explain to all of us what your investment strategy is? I really don't understand it. And you know what Bernie Madoff said to Joe? Joe, I'd be happy to, but you wouldn't understand it. And he said, oh, okay. And they never asked another question. 3 months later, the fateful day came, and in 48 hours, they went from hundreds of employees, philanthropic activities in Israel and the United States, to zero, close the door, out of business. All the money was gone. It doesn't have to be that way. Boards should be active. Boards should be engaged. Boards should ask the tough questions. If you show me a successful management team, I'll show you a successful board behind them, who are challenging them all the time to think big picture, to innovate, to expand, to explore new options. And if they hear that the government's giving money away, find out how we can get some of that.
Carson and I did a webinar recently called ACO Leadership, ACO Boards and Leadership, the difference between success and failure. And I really think that's the truth. I think, you know, that the leadership of the senior management and the board members sets the tone for whether this organization is going to succeed or fail. But you know, there's no question, but that does take some work and some training, right? Because in particular, if you're talking about the MSSP ACOs, there are all all of this is new. There are all kinds of regulations that you have to be aware of. There are all kinds of constraints that you have about how things, have to be done. And, an ACO board is responsible for that. And they need to understand what it is they're responsible for, right? So there's understanding what you're responsible for, but then there's also having...
And taking responsibility for it.
And taking responsibility for it. And then there's also, having the training to know, what as a leader do you need to do to be sure that all of your providers are rowing in the same direction, right? That you're all aiming towards serving the patient as best that you can.
The second thing after leadership I would think about evaluating are the risks, are the challenges, are the headaches associated with embracing a new model. And like everything in healthcare, there's plenty of regulations, there's plenty of law that applies to it. I read one time that healthcare in the United States is the second most regulated industry of all. Nuclear power is the only thing that's more regulated than healthcare, probably for good reason. But think about the regulations that you deal with right now, and then lay the ACO over the top of it. What are the challenges in risk management? The development of these new models, I guarantee you, is already creating new models in the minds of plaintiffs' attorneys for lawsuits they'll bring for professional negligence around credentialing, oversight, and so forth of the activities of the provider participants in the organization. Reimbursement issues, fraud and abuse. What kind of compliance program and training do you have in place, not just for your practice or your hospital or your long-term care facility, but for the ACO? So that staff understands that they could, as an ACO, be exposed to problems. Do you have the right governance structure? The rules say that 75% of the board of directors of an ACO must be provider participants, mostly physicians usually. One person on the board must be a patient advocate representative, a Medicare beneficiary. Actually, one granny from the community needs to be on the board. Now, I would guess, and I'd probably be willing to bet, see, I'm from Kentucky, we wager every now and again on things. You've probably heard of the Kentucky Derby, it's a pretty famous thing. So we like to bet on horses and stuff. So I would bet you right now that if we went out and we picked a really nice elderly woman to be on the board, she's going to need training. She's probably never been confronted with this kind of an opportunity or a challenge. So thinking about their viewpoints and how you integrate that into, now let's say you've got a 12-member board, you're down to 2 people. 75% of them have to be basically physicians, that's 9. Granny's number 10, so who are the other 2 people? Now, what if you're trying to do a partnership with a United Healthcare or Universal American or somebody like that? They're going to want some special relationships in structuring this thing to protect their investment if all they have is 2 board members, right, out of 12? So you got to think about that. Well, how can we knit this thing together so that they feel protected, but we have the freedom to do what we need to do for patient care? These are all challenges. They can be overcome if you have the right team of people looking at them and advising you, but they are legitimate issues that need to be addressed.
And some of that really comes down to, right, the relationship between the payer partners and the participating entities, right? There's got to be a relationship of trust there and of confidence, you know, on all sides, that you're all kind of in this together and taking care of each other. You know, payers sometimes want to see, you know, do these entities really have the structure, the infrastructure in place to truly be accountable, right? And so sometimes entities go through NCQA certification process, ACO certification process. It's not something you have to do. It's totally voluntary. It's not like the MSSP application process. But, you know, the NCQA accreditation process, you know, may be one way that you can kind of check the box and, you know, let payers know that, you know, NCQA has determined that your infrastructure is there and you actually, you know, you have what it takes to be accountable and to meet your goals.
Carrie, I'm told we have about 5 minutes, so let's just hit one more item that I would be concerned about and discuss that, and then maybe wrap up.
Yep.
Financing. As our friend back here pointed out, he'd heard that Billings had some financing difficulties when he got this thing started. It doesn't shock me. When you start up anything new, you've got new costs and overhead and so forth that you gradually, when you're running a business, you start to generate the revenue and begin to break even and hopefully make a profit. So where are you going to get the financing? Well, the government has some programs, and that's good, but they're not financing the whole thing. I just want to hit on one suggestion to you. There's a little-known group of organizations in this country called conversion foundations. Now, under the law of not-for-profit organizations, when a not-for-profit, in our conversation here, health system, is sold to a for-profit entity, the money that the not-for-profit receives from that sale must be invested in something they have to create called a conversion foundation, converting from not-for-profit to for-profit status. They can't declare a dividend and have a party. They have to reinvest it in the community where the money came from. Now, there are over 200 healthcare conversion foundations in the United States. Some of them have millions of dollars. A few of them have over $1 billion in cash in the bank, and by law, they are required to invest that in healthcare activities that will improve the quality of care in their locations. Now, I don't know off the top of my head how many are in South Dakota. Most states have a couple. There's over 200 of them in the United States. I would turn my attention to a conversion foundation and say, you need to give me some of that money so I can help improve the health care of the people in this community. There's lots of money out there. You just got to go after it.
And the point of all of this is, you know, it's time to kind of think outside the box.
Absolutely. Theismann was right about that. Got to be creative.
Creative ideas and creative thinking. So, Carson,
so we need to wrap up.
Yeah, give us some action items that we can take away.
Well, the first thing you need to do is put a team of advisors together. Maybe some people internally, some people externally that you trust and you think have the credentials and the background, the expertise to help you navigate this minefield of trying to become an ACO. That's money well spent. People who've been through the process or been through something similar to it, understand the regulatory agencies and know how to deal with these folks, can be invaluable in helping you eliminate some of your headaches. So put your team together. Then turn the team loose on looking at your options. Think outside the box. Be creative. Why did Billings do that? Why did Coastal Carolina do that? How would that work for us? Would telemedicine or teleradiology be a good thing? Where are the partners we could find to implement that? So turn them loose to explore all options. I used to tell my staff, there's no such thing as a bad idea unless it's illegal. And I will tell you if it's illegal. So bring me every bad idea you got. And the final thing is take action. Get up off your duff and go out there and do something. But if you're not going to do anything, don't do the first two steps. You just waste a lot of time, energy, and money. So if you got questions about all this, I know there's another session about to happen somewhere else, and you probably need to get to it. Carrie and I are going to stay through the evening. Believe it or not, it's not that easy to fly back to Washington, D.C. So we're going to do that tomorrow. So we're going to be around, and we'd love to meet you individually. If you want to continue the conversation, we'd be happy to do that. If you want some further professional advice, we'll get in touch with you. You can get in touch with us, and you got the information on how to locate us. But we've had a great time. We went to a wonderful restaurant last night and enjoyed the fellowship, and I was truly amazed by Theismann today because all I do is see him on TV at home talking about football, and he was very impressive, and I think he did a great job of getting your convention launched. Hopefully, we shared a little bit of expertise with you about accountable care organizations that you can take away and use.
Yeah, y'all have some great things going for you. I mean, some of the things that I'm seeing and hearing and talking to you all are some things that aren't going on in other areas of the state, right? They have a lot to learn from you all. And so, you know, and that's kind of part of what got you where you are, which is, you know, you're already providing some really good quality care at pretty good cost. So, you know, you all have a lot to share and a lot to offer. And, you know, I thank you all for inviting us here to talk to you. Y'all have been very warm and welcoming, and we look forward to continuing the conversation.
Go forth and prosper.